So today's class is going to be about presbyopic laser vision correction, especially the cornea-based procedures. Just a brief overview about what we'll be covering today. So we'll be covering about the mechanisms of how we are treating the cornea to achieve a presbyopic correction, the platforms which are available today, and what are the advantages. We are not going to go into the outcomes and the challenges and which procedure is to be done for which patient, and also whether or not to choose them over multifocal IOLs. So that will be a separate class. Today we'll be going through majorly the platforms and also the planning which is involved in all of these three platforms, which is slightly different from each other. So as we know that correcting presbyopia is a challenge in itself. The patients need clear vision for both distance, intermediate, near, all that time while maintaining optical quality without any loss of vision, with good night vision, no loss of contrast, with good depth perception and stereopsis, with a good patient tolerance, less adaptation time, also correction of the refractive error at the same time, and also having the option of reversibility. So it is a really big challenge to correct presbyopia. Briefly, presbyLASIK is of three types: central presbyLASIK, peripheral presbyLASIK, and laser blended vision. Peripheral presbyLASIK is not done nowadays, so we'll be focusing our attention on central presbyLASIK and laser blended vision. Central presbyLASIK is done via three platforms: the AMO VisX, PresbyMax, and SupraCore. AMO VisX nowadays is not available. So right now we have PresbyMax, SupraCore, and laser blended vision, which is given by PresBeyond. Custom Q approach we'll not be discussing in this class because it's not done that frequently. So the three platforms that we'll be discussing today are the PresbyMax, SupraCore, and PresBeyond. So even coming before to the kind of treatments that we can offer to the patient, the first thing is to give a lot of chair time to the patient and get a detailed history, especially focusing on the patient's lifestyle expectations, the refraction and the visual acuity for near and distance, dominance of the eye. The size of the pupil is an especially important factor when it comes to presbyopic corrections. The size of the pupil in dark and in light, that is photopic and photopic conditions, need to be assessed. Normal routine LASIK evaluation needs to be done, and patients need to be filtered out according to the contraindications for general LASIK as well. Detailed ocular examination, especially ruling out any hints or traces of cataract, and treatment of dry eyes whenever necessary. So a few important points to note is that the patient motivation levels should be very high. The patient should be able to accept the trade-off. The trade-off in presbyopic correction is the side effects, the monovision, time for adaptation, unpredictable uh, outcomes, and some amount of spectacle need, especially for very fine print or far distance. The adaptation time has been said that it is similar for myopic or hyperopic presbyopes, but for plano or emmetropic presbyopes, it is the longest. On an average, the adaptation time after a presbyopic correction is up to 4 months. So we need to make the patient aware of the fact that it is not like normal routine LASIK wherein you get a wow factor. The patient actually needs to get adapted to the vision, and then by the end of 3 months, they will have satisfactory visual outcome. One more important point to note about preoperative evaluation is to check the preoperative corneal spherical aberrations. The importance of spherical aberrations I will explain later, but preoperatively we need to note the corneal spherical aberration as well. And an essential and crucial part in all presbyopic corrections is to check for binocularity, stereopsis, depth perception, contrast, and binocularity in all patients, because the treatment hinges upon binocular vision. So if the patient does not have good binocular single vision, they are not a good candidate for presbyopic correction. And another important part is to customize the treatment according to each patient, their refractive error, functional age, and functional how much of presbyopia they have, and their occupational needs. So a brief about dry eye, why dry eye is important, especially in presbyopic corrections, is that it is done in slightly older age group. They have slower wound healing. They have a bit of more dryness in their eyes and a bit of more MGD as compared to the younger patient group which undergoes LASIK. So dry eye evaluation and treatment is crucial. It is best to avoid PresbyLASIK in conditions like ARMD, DR, and optic nerve pathologies because their contrast vision is already poor. And assessment of strabismus or the use of prisms preoperatively is important as patients can sometimes experience diplopia after these procedures. So the overall experience has been that the satisfaction rates after presbyopic corrections are higher usually with hyperopic presbyopes than with myopic presbyopes. In beginner surgeons, most of the faculties they advise that you correct one eye for the distance and the other eye you give micromonovision, the details of which I'm going to go through later. And initially in your practice, avoid high hyperopes and high myopes. So coming to testing the dominance of the eye in the OPD, it is a very easy procedure. We can tell the patient to make a small hole in their palms or the fingers and tell them to selectively look at a target. The eye in front of which the patient takes their hands is the dominant eye. Usually we do 3 or 4 of these tests to determine the dominance of the eye, and we see the repeatability of the dominance. If the patient sees the same eye dominant in 3 or 4 of these tests, then we are sure that the patient has one-sided dominance. Most important thing before operating on a patient for presbyopia correction is to actually see how well they tolerate the micromonovision. So how do we test for micromonovision and its tolerance? So the step one is to do complete refraction, possibly cycloplegic refraction, especially in hypermetropes and emetropes, good distance correction, and after putting good distance correction, you occlude both the eyes. In front of the non-dominant eye, you put a plus 1.5 diopter lens. You tell the patient to open their eyes and reveal the chart. After seeing at the chart, you ask the patient if it still looks similar and if the patient has any obvious blurring of vision or ghosting of the images. If the answer is no, then you give them the near chart. In the near chart, you see how much the patient is reading binocularly. All of these tests are being done binocularly. If how much is the patient reading N5, N6, N8, and so on. After assessing the near vision, you again show the distance chart and see how much patient is reading binocularly, maybe 6.6, 6.6 part, 6.9, 6.12, whatever. So the trick is if with the plus 1.5 diopter lens in front of the non-dominant eye, patient has satisfactory distance vision as well as satisfactory near vision, only then the patient is a good candidate for the presbyopic correction. So for example, if we have put 1.5 diopters in the non-dominant eye and the patient appreciates the blur in the non-dominant eye, then we can reduce the add by 0.25 diopters and repeat the test and then see if they are tolerating little less plus power in front of their eyes. And maybe if the patient is young, we can take them up for a slight under correction of the presbyopia, but not beyond that. If the patient is not N6, even with plus 1.5 diopters in the non-dominant eye, but the patient is tolerating the blur well for distance, possibly you can increase the add to plus 1.75 diopters and then repeat the test, but we will not go beyond plus 1.75 diopters as it creates too much of ametropia in both the eyes. So till now we have discussed what all to see, what expectations the patient has, and how to evaluate the dominance and how to evaluate the micromonovision tolerance of the patient. Having understood the preoperative evaluation, let us come to the kind of surgeries we can offer to the patient. The first surgery being central presbyLASIK. So central presbyLASIK by itself means that there is a central near area, then is a transition zone, then there is distance vision area, and then there is untreated cornea. So the central near zone is steep. Then we have an intermediate zone which is relatively steep, and then the distance zone which is flat. And after that, there is a transition zone. The main important point to note in all the central presbyLASIK treatments is that you are generating multifocality on both the corneas. The amount of multifocality and the power of the multifocality may vary in both the eyes, but each eye by itself will become multifocal to some extent. Having said that, one important point to note here is that it is a pupil dependent procedure, and the central zone for near is considered more physiological, and that's why we are not doing the peripheral model. Why? Because during the near response, when the patient is reading, the near triad is accommodation, meiosis, and convergence. So during accommodation, the pupil is going to become smaller and the patient is going to see through the central 3 millimeters. So this is going to be more advantageous. Second thing, another advantage of doing central presbyLASIK is that since we need steepening of the cornea in the center, we don't need to ablate the cornea in the center to a higher extent. Where the cornea is the thinnest in the center, we don't need to ablate very much. In the periphery, where we need to create flattening for the distance and intermediate areas, where anyways the corneal thickness is higher than the center, we are flattening that area and having higher levels of ablation. So it works in our favor. So similarly, like I said, this area pupil has constricted, and for near adhesion zone, the rays are falling onto the retina. Patient is comfortable in reading. For distance, we are going to have the paracentral area. The pupil is going to dilate and the light passes through the outer part of ablation in the 3 to 6 mm zone. So central presbyLASIK has broadly two types. Two types being PresbyMax by Schwind and SupraCore by Tinio. So I am going to explain to you about what PresbyMax means. So PresbyMax, if you look at the diagram on the left and the right, I'm going to explain it to you. I just want you to look at the diagrams. So the treatment in the distance eye on PresbyMax platform is varying. In the right, in the dominant eye, you can have micromonovision, you can have hybrid treatment, or you can have monocular treatment. However, in the non-dominant eye, the treatment remains the same. So let me take you through the journey of each treatment. In the micromonovision treatment, in the distance eye, that is the dominant eye, the center is going to be minus 0.9 diopters target, around minus 1 diopter target, whereas rest of the area for distance, the patient is going to be plano. So in the right, in the dominant eye, the patient is going to have some near or intermediate ability, but great for distance. Contrast to that, in the non-dominant eye, the central part is going to be minus 1.8 diopter. So it's going to be very steep, and this is going to be the primary source of near vision for the eye. However, in this eye, in the non-dominant eye, the patient is going to be minus 0.9 diopters myope, which is going to give him good intermediate vision and is going to compromise a little bit on the distance vision. So patient is getting good distance vision from the dominant eye, fair bit of near and intermediate vision from the dominant eye, good near vision from the non-dominant eye, and fair bit of intermediate vision from the non-dominant eye. If we come to this graph, we can see that in the dominant eye, the patient is reading far distance and up to 1.5 or 1 diopters for near, and the non-dominant eye is going to take care of your intermediate and near needs. One thing important to note here is that in the non-dominant eye, we are correcting up to minus 1.8 diopters, which is minus 2 diopters. Okay, so the near point of that patient is going to be somewhere around 50 centimeters. So if the patient is having good near visual acuity N6 at 50 centimeters, what is the use of doing this correction? Anyway, that patient who is a presbyope, naturally their affinity is going to be to put the distance from 35 to 40 to 50 centimeter as the patient is going to age. So by doing this treatment, we are simply giving the patient good distance vision at 50 centimeter, which was anyway achievable by the patient just shifting the object far away. So even though the amount of correction is close to -2 diopters and the clear near point is 50 centimeters, the treatment itself induces negative spherical aberrations into the cornea. So let me give you some background. The normal corneal aberration is plus 0.26 microns. Our cornea is slightly positive spherical aberrations. When we give the cornea negative spherical aberration, the depth of focus of our eyes increase. What do I mean by that? The depth of focus is that range of vision in which even without accommodation or moving the object, you are still able to see clearly. So functionally, although the patient's near point is going to be at 50 centimeter, because of the additional negative spherical aberration induced into the patient's cornea because of the unique profile of correction, the depth of focus of the patient is going to increase and the effect is going to get up to 2.5 to 3 diopters. That is why we don't need to correct the patient up to 2.5 to 3 diopters in all ages. Similarly, in the second type of treatment, which is the hybrid treatment, the near part in the distance eye is going to be only minus zero point 0.4 diopters. So very minimal near vision. The patient is going to get some amount of intermediate vision. For distance, the patient is going to be plano, so he will have great distance vision. In the non-dominant eye for the hybrid treatment, the parameters are the same. In the monocular treatment, the patient is plano for distance as well as near in the dominant eye. So the patient is going to read great at distance with the dominant eye. However, he is not going to have any intermediate or near vision from the dominant eye. The significant intermediate and near vision is going to come for the patient by the non-dominant eye itself. So in the hybrid, as we can see, if we compare the micromonovision and the hybrid eye, compare the dominant eye, the range of vision in the dominant eye has reduced because the correction for near is reduced. Similarly, in the monocular treatment, the dominant eye is plainly for distance and the non-dominant eye is going to take care of your near and intermediate needs. Sir, shall I go forward, sir? Is that clear, sir?
Yes, you can. To me, it's clear. If anybody else has any questions, then good idea to ask.
Yes, sir.
Shruti, you
So,
wanted to ask anything? Did you get it?
No, no, you can go ahead, Pranav.
okay. So let me take you through how the patient gets decided on which treatment to undergo. So if the patient has an anisometropia tolerance of more than 1 diopters, only then we are going to do any presbyopic treatment. So the first step is to check for tolerance for anisometropia. If anisometropia tolerance is low and if the patient is not tolerating it, there is no treatment possible. Second criteria is the photopic pupil size, which should be between 2.5 to 3.5 mm. If the pupil size is too small or too large, the central 3 mm is not going to play a good role in the patient's near vision. Scotopic pupil more than 4.5 mm, ideal for distance vision. Yes, only then we can go forward. Then let us check the acceptance of increased recovery time in distance for better stereopsis. What I mean by that is that does the patient tolerate distance blur in order to get good stereopsis? In order to get good stereopsis, we are going to have a near add in both the eyes. But if the near add is not well tolerated by the patient for distance, then we will go for a hybrid treatment. In hybrid treatment, as we saw, the patient does not have to tolerate that much because the near eye also the distance eye also has some amount of near and intermediate correction. If the patient is able to tolerate the blur very well, then we can go for micromonovision in which the distance eye had a lot of intermediate and near correction. So the basic thing is, if we are offering micromonovision to the patient, micromonovision means in the dominant eye, apart from the patient being distance correction, we are giving some amount of near and intermediate correction in the distant dominant eye. So in the distant dominant eye also, in micromonovision, we are sacrificing some amount of clarity and quantity of distance vision. Okay, so if in the distance vision the patient is able to tolerate some amount of blur, then we are going for micromonovision. If the patient is accepting only a little amount of distance blur in the dominant eye, we will go for hybrid. And if the patient is not at all accepting any blur for distance in the dominant eye, we have only one option, is to go for Presbymax monocular treatment, in which the distance eye is purely for distance and the near eye is giving you near and intermediate vision. So these are a few inclusion and exclusion criterias which have been decided by the Presbymax guidelines by Schwind, in which important points to note are that age more than 40 years, anisometropia acceptance of more than one diopter, spherical equivalent and astigmatism range of treatment is somewhere around -8 to +5 diopters, astigmatism of 4 diopters, preoperative add of 2.5 diopters. One more important point to note here is that corneal spherical aberrations should be positive preoperatively. More than 0.0 means that corneal spherical aberration should be positive preoperatively. And the entire ocular spherical aberrations, according to our eye trace or any aberrometer that you have, should be more than -0.2. It should not be already too negative. The higher order aberrations also should be less than should be less than 0.5. Okay, because all of these treatments, neither are they wavefront guided nor they are topography guided. They are plain and simple wavefront optimized treatments. Why do we have to do wavefront optimized treatments? Because we want to in fact generate more negative spherical aberrations. If we were to do a topography guided treatment or a wavefront guided treatment, inherently it is going to correct and also prevent induction of higher order aberrations, which include spherical aberration. So by default, all of these treatments are going to be wavefront optimized, and the fact that wavefront optimized is going to induce some amount of negative spherical aberration, we are using it to our advantage. And I will not take you into the details of how we are going to treat each degree of hyperopia, myopia, pseudophakics, and everything. Maybe that can be discussed in another class. So important to note
So,
is that,
Pranav, you have to tell us that
yes,
is
sir.
Presbymax being used extensively right now, and which is the age group or the range of hyperopia, presbyopia, where it works best? See,
Sir,
because presbyops can be right from 40 to 55, right?
sir, yes, sir.
So,
So, uh, normally, whatever I have read from Indian studies and Indian faculties, most of them now have shifted to Presbyon. Presbymax and Supracore are being done in certain centers. Their patients are happy, but their population is somewhere around 40 to 50 or 55. Beyond that, they are not doing it. In European or American studies, we have seen that their trend for getting cataracts is a bit later. So they have also done it up to late press biopsy, maybe 55 to 60 to 65, wherein the patient is needing the full plus 2.5 or plus 3 add. So this is in India, PresbyMax, SupraCore, and PresBeyond are working extremely well, especially in patients who are low or moderate hyperopes, and not low or moderate presbyopes. In high presbyopes, it is not still very well used.
so what I mean to say is that if somebody at 45 came to you with an ad of, say, he's using an ad of plus 1.5, what would you offer? Like, how would you counsel the patient?
Yes, sir.
Patient is
So
a plano presbyope
plano presbyope, sir, we
and
can.
keen for, yeah,
Sorry, sir.
plano presbyope keen for a correction.
Yes, sir. If if like I said, all the pre-op evaluation and the DLI and everything is normal, I will counsel them to go ahead with presbyopic correction, but I will not offer them PresbyMax. I will offer them Press Beyond.
Okay. And how will you tell the patient that how long will the benefit last? And how much correction are you going to offer them?
Yes. So the amount of correction on Presby Max, a maximum near add that we can add is around plus 1.75 diopters. The rest of it is being taken care of by the increased depth of focus for the negative spherical aberrations. So what we are going to tell the patient is that the effect is going to last for only 5 to 10 years up till you are going to go 2.5 diopters of near add. After that, you are going to need glasses which are going to be very thin and you're not going to need them all the time. But after post 60, you are going to definitely need glasses to read fine print. Say you're reading newspapers or you're reading fine print in our medication instruction charts or whatever. They are still going to need small amount of correction for near. Dependence will be less, but they will need.
Okay. Also, what, how much is the possibility of regression with these treatments? Number one. And
Yes.
number two, uh, that patients, when you're counseling them about blur, so how much is the distance blur which is caused? Because basically you are creating monovision with this,
Yes.
right? So
Yes, sir.
I'm just wondering that why not then just create monovision? Why go with, you know, with something which
Multifocality
is
onto the cornea.
right?
Yes, sir.
Because
Matlab, that
anyway,
is.
we are inducing, like in one eye, you are already inducing a minus 1.5 or 1.75.
Yes, yes, yes. So, sir, nowadays, what after having treated a lot of patients, what faculty say is that hyperopes tend to regress toward hyperopia and myopes tends to regress towards myopia. So, in hyperopia, they want you to aim for little bit of myopia. Minus 0.5 is the target, but after having seen the regression patterns in hyperopia, they say you aim for minus 0.75 for distance. I mean,
Okay.
in myopia, by default, for myopia and hyperopia, both their targets were minus 0.5 for distance. In hyperopia, now they have modified it, make it minus 0.75 in hyperopia because the patient is going to become a hyperop sooner rather than later because of regression. Myope is going to become more myope. So now, instead of minus 0.5 target, in myopes, what they say is you give a minus 0.25 target.
Yeah.
Yes, sir. So, like I was saying, sir, in hypermetropes, now our target is minus 0.75, and in myopes, it is minus 0.25.
Hmm. Fine. We understand now.
Yes, sir. Yes, sir. So now, sir, coming to a few authors have also said that just simulating it with the trial frame is not enough. We need to do a proper multifocal contact lens trial prior to the surgery. So let me tell you how we will do the contact lens trial prior to surgery. If we are planning a micro monovision treatment, if you're planning a hybrid treatment, and if you're planning a monocular treatment. Micro monovision we will do when the patient is tolerating distance blur very well. Hybrid, moderate tolerance to distance blur. And monocular when the patient does not tolerate distance blur at all. Okay, so on that basis, the distance dominant eye in all three of them is going to be plano. We are going to completely correct the distance vision in the dominant eye. In the near eye, which is the non-dominant eye, in all three of them, we are going to give a minus 1 diopters myopia. Now coming to the add power, in micro monovision, we will give medium add power in both the eyes. In hybrid, for the distance eye, we will give low add power and non-distance eye medium add power. In the monocular, for the distance eye, we will give no addition, and for the non-dominant eye, we will give medium addition. So at this juncture, I would request Mr. Biman Das to also give his inputs as to how we are doing the multifocal contact lens trial. Biman sir, please, if you can help us out.
So usually we give that contact lens trial for a presbyopia, which is available in India actually only for the spherical power. We are not offering any kind of a cylindrical power. That is one things we have to keep in mind. And then we usually give for a distance for dominant eye for the distance and non-dominant eye for the near. So there are some companies like that. Bosch and Lomb, they provide actually multifocal in daily disposable as well as monthly disposable. And Johnson and Johnson, they provide also daily disposable as well as biweekly disposable contact lenses in multifocal contact lenses. So what is their nomenclature is like that. If any person whose ad is still 1.5 diopter, like a plus 1.5 diopter, irrespective of whatever the distance correction, then we should actually go for actually something called as a low ad. And if it is a beyond something like that 1.5, then you have to go for actually the high ad. This is the contact lens prescription. So for example, if the right eye is like a plano plus 1.5 diopter, that is near ad, and another eye also like a plano with plus 1.5 as a near ad, that's a spectacle power. And the patient say right eye is actually the dominant eye, then you just prescribe actually plano with low ad, as well as your left eye also will be like a plano with as a low ad only. So they always say like that you start with actually low ad, then you go for actually the higher ad. Then we prescribe actually something called contact lens, called actually as a modified monovision. And that cases we prescribe the distance eye, like a dominant eye for the full distance correction. And the non-dominant eye, we prescribe actually multifocal contact lens that correct for the distance as well as near. It is called as a modified monovision. And the third one is like that you give actually prescribe actually one eye actually as a distance correction and another actually give actually as a near correction, that is called as a monovision. So mostly we prescribe this kind of the contact lenses whoever is coming for presbyopia correction. So a simple way like that, if any ad is below 1.5 or 1.5, you go for a low ad, and if it's above 1.5, you go for a higher ad. That is the prescription for presbyopia.
Okay, thank you. Sir, shall I go ahead?
Yes, you can. Yeah.
Yes. So now
Thanks
just
very
a
much.
brief overview of how the treatment planning will look on the Presby Max. We are doing a Presby Max hybrid treatment. Okay. So distance eye is the right eye. So we have already mentioned the dominance of the eye over here. How much is the addition? Around plus 2 diopters. It is a bi-aspheric treatment and it is the hybrid type of treatment. So important point to note here is that in the distance eye, the refraction was -1 sphere and -0.5 cylinder. The target here has been set to plano. So if we look at the amount of ablation which is occurring, it is highest in the center and reduces to the periphery, which is similar to the LASIK myopic correction. Then in the left eye, which is the non-dominant eye, in which we are going to give the near correction, we can see this donut pattern. Donut pattern means in the center, we are leaving it untouched or treating it very less. Why? Because central part, we want it to be steep. In the mid periphery, we are giving more ablation and creating flattening. And then again in the far periphery, it is steeper. So one eye is distance, second eye is going to be near and intermediate, especially this donut pattern we'll be able to see. Important point to note here is that this target here in the PresbyMax is not -1 diopter. I have not understood why in the PresbyMax system they have used figures like 0.89, 0.9, 0.4, 1.8 rather than -1.5, 2 diopters or something like that. Something might have been according to their nomogram or something, but their target is -0.89, that is -0.9, like we discussed before. So this is the point to note. In the near eye, the target is more myo. Okay. So one more important thing to note about Presby Max, especially for the patient and the doctor himself, is that in Presby Max, you can do reversal of the treatment on the click of one button itself, because Presby Max allows you to retreat and reverse the biaspheric profile of the cornea. So this is the treated profile in which the center is very steep and looking for near and then intermediate and then far vision. For reversal, immediately we have one option and at one click we are able to reverse the treatment and create normal correction. And if you were to see, one more important thing I forgot to mention here is that the ablation depth, please note here the ablation depth is very minimal. It is only around 26 microns, and here it is only around 9 microns and 25 microns. So what I mean to say is, over and above the additional correction, I mean to say if you are correcting the refractive error and you are adding a presbyopic correction onto it, it is not consuming a significant chunk of your cornea. So even if you are doing a presbyopic treatment, because you have done presbyopic treatment does not mean that you cannot retreat and make the cornea again in terms of corneal thickness. We are ablating very little to create the desired multifocality. So to reverse also that multifocality, we are ablating a very small amount of tissue. So it is safely possible.
Pranav, here you might want to add that it also depends upon the refractive error of the patient that you're correcting, because it's not necessary that all patients will be plano presbyopes.
Yes,
You
sir.
may be
Yes, sir.
combining
Yes.
it with a refractive correction also, and that will have some ablation depth. So
Yes,
this
sir.
is only
Yes.
the additional ablation depth which you will be firing.
Yes, yes, yes. I mean, in terms of like high hyperopes and high myopes, that's why they are told for beginner surgeons to avoid, because if the patient is not satisfied and if at all you want to reverse the treatment, then we'll be in a soup. So we'll start with little bit moderate myopes and hyperopes. In fact, hyperopes are very happy because they get great distance vision and great near vision. So they are very happy. Myopes are not happy because they are used to having good near vision without glasses, and now distance vision is also a little bit compromised, so they are not really happy.
So, if you do hyperopes, just do standard hyperopic LASIK wavefront optimized also, they do extremely well because they get great distance vision, and they also have a significant, because the cornea becomes hyperprolate. Okay,
Yes,
just with
yes,
standard ablation, the Q value goes into like minus 1.5 or something.
absolutely,
Okay.
sir. Correct.
So those patients actually get great reading vision and they are very satisfied. They hardly use reading glasses.
Yes, sir.
So
Yes, sir.
actually, treating hyperopes is a very, very simple thing. You don't even have to do any presbyopic LASIK or anything. You can just do a regular standard wavefront optimized ablation and get a great distance and some decent near vision as well. It
Yes,
is the
sir.
myopes which are more challenging. So
Yes,
that
sir.
is where you need to be more careful.
So that additional benefit that you are saying in hyperopes we are getting for reading especially is because we are inducing that negative spherical aberration by default, because we
Exactly.
are
You're
making the cornea
inducing a negative
hyperprone.
Q value.
Yes,
Right. You're
yes,
basically making the cornea hyperprolate and
yes,
you're inducing a negative Q value even with a standard ablation. So
yes.
in presbyopic hyperopes, if you do just a hyperopic correction, they do extremely well and they are very happy patients because their near vision also improves drastically.
Yes, sir. Yes, sir.
Okay.
But sir, I will show in the later slides that by creating this multifocality of the cornea, the depth of focus will still be higher than normal hyperopic LASIK patients.
I agree. That obviously will happen because you are then causing an even slightly more, additional impact of the presbyopic correction. So obviously that will be slightly better, and you will get. I agree. Okay. आगे चलते हैं.
Yes, sir. So coming to supracore, it is performed by the Technolus Tinio platform. Similar funda, both the corneas become multifocal by itself. Central area is near, paracentral is intermediate, far area is distance, then the transition zone, then untreated cornea. It is a biaspheric profile. So in this, what they do is they create a central 3 mm 12 micron elevation. So they have quantified that also. There is a 12 micron elevation of the central 3 mm zone, which is the near addition, almost two diopters. Intermediate zone is going to be the distance zone, and same thing without accommodation. I mean, with accommodation, the pupil constricts eye sees through the central zone, which is for addition. Now, we might say that the light which is passing through the mid peripheral zone will not focus perfectly onto the retina and will slightly, cause a blur for distance vision. But studies have shown that there is 300% more light which passes through the distance zone than the near zone. So it reduces the impact of the blur which is provided by the light which is getting deflected for the near zone, especially when the pupil is more than 5 to 6 mm. Now coming to the treatment planning and the targets for supracore. In default, refractive target for supracore is not plano but minus 0.5 diopters to further enhance the 2 diopter addition of central near zone. So distance also we are not aiming for plano. In supracore we are aiming for minus 0.5 for distance as well. And the near add we are inducing 2 diopters. So eventually it becomes around 2.5 diopters. So this is going to make the near uncorrected visual acuity somewhere N6 to N8, but at the cost of distance uncorrected compromise somewhere around 6.6 parts to 6.9. So it is a fine line that we are walking between near and distance vision in both the eyes and achieving binocularity. So another point to note here is that binocular single vision is the single most important thing we need to check before operating for presbyopic correction. If the patient does not have good binocularity, the patient is going to have very poor outcome. So this is the kind of corneal profile we look for after a hyperopic supracore treatment and after a myopic supracore treatment. So the central corneal steepening here also is going to induce a negative spherical aberration and give a better depth of focus. So supracore treated eyes versus hyperopic LASIK treated eyes, we have seen that there is more negative spherical aberration in the supracore group because we are actually inducing negative spherical aberration in hyperopic LASIK patients. It is by virtue of the treatment that we are doing, we are getting the negative spherical aberration. So how do we plan supracore in hyperopes and how do we plan supracore in myopes? In supracore for hyperopes, it is a bilateral treatment approach. In the dominant eye, we do something which is called as a soft supracore, in which we give only plus 1.5 diopter add. This is in addition to the minus 0.5 distance target. In the non-dominant eye, distance target is still going to be minus 0.5 diopters, but the near target is going to be a something called as regular supracore. So we have two new terms. Earlier it was micro monovision, hybrid and monocular PresbyMax. In supracore, the terms are soft supracore and regular supracore. Soft supracore, dominant eye is going to get plus 1.5 diopters add and regular supracore plus 2 diopters add. For supracore in myopia, we do only a monolateral treatment approach. In the dominant eye, we do a normal wavefront optimized LASIK. In the non-dominant eye, we are straight away doing regular supracore with plus 2 diopters add. So this is the kind of treatment planning that goes in supracore. This is the supracore user interface in which we are selecting the supracore option. This is the mild supracore version because this is the dominant eye. In the dominant eye, the target here is minus 0.5 diopters. This is the ablation profile. Maximum ablation is around 22 microns. Central ablation is 14 microns. We are ablating less in the center because to create the small amount of hyper positive or the hyperprolate area in the center. So the ablation in the center is lesser, in the mid periphery it is higher. Now coming to the non-dominant eye. In the non-dominant eye, again for distance, the target is minus 0.5, but we are doing a regular supracore. For regular supracore, the central ablation remains the same, but the central ablation remains the same and the maximum ablation in the periphery gets flattened a lot. So consequently, the center becomes more steep. Is that clear, sir? I mean,
Yes.
so coming to the problems with PresbyLASIK, by PresbyLASIK I mean supracore and PresbyMax, which is creating multifocality on each cornea. The problem is that there is initial compromise on distance vision. The patient is going to have blurred distance vision for up to 3 months till he gets adapted and till the epithelium heals. Second thing is adaptation problems to multifocality. And third thing is night vision problems in the initial period and also reduction in contrast sensitivity. So why can't we adapt to multifocal treatments easily? So there is a thing which is called as interocular competition or intraocular competition. So normally, naturally, physiologically, our eyes are used to interocular competition, which is the competition between the right eye image and the left eye image. And that is the whole basis of our amblyopia and visual development and everything. So inter-eye competition is a physiological phenomenon. So even though my right eye is seeing good for distance but blur for near, and my left eye is seeing blur for distance and good for near, the two eyes giving different images, two different images from two different eyes is tolerable to us. But in multifocality in the same eye, you are getting two different images from two different portions of the cornea, and this inter intraocular competition within the same eye, two different images if you are getting, that is not a physiological phenomenon, and the brain is not able to tolerate it very well. So that is the problem with adaptation. So initially our approach was to give full multifocality in both the eyes, and they have noted that loss of best corrected visual acuity. Please note here, this is not uncorrected visual acuity, this is best corrected visual acuity of two lines in at least 12% of the patients, which was very high. So then we shifted to giving reduced amount of multifocality. So by aspheric multifocality was given, but micro monovision. Okay, so the ad was lesser and the targets were little bit different to create little bit of micro monovision. So the loss of two lines from 12% went down to 5%. And now we are giving micro monovision and blending the vision, wherein the distance target and the near target both are different in the eyes. We are creating lesser amount of multifocality in each cornea, and we are trying to blend the optical zones and the range of visions of the eyes, and that has been tolerated really well, and the loss of lines is almost negligible. So that is also how the Presby Max treatments also have developed, wherein we create a lot of multifocality in micromonovision treatment, little bit of multifocality in the hybrid treatment, and almost nil multifocality in the monocular treatment. So what are the challenges? Okay, so now we have said that multifocality is a problem, but monovision by itself also has its challenges. What are the challenges in monovision? Monovision, there is an intermediate blur zone. If we treat for near, then the distance vision loss is there. Loss of stereo acuity is there. If the depth of perception and the range of vision do not match closely, you are going to have loss of stereo acuity. There is going to be loss of summation, and the patient is not going to tolerate it very well. So Dr. Graham Barrett, whose formula we constantly use, he has suggested something which is known as modest monovision. Modest monovision, he said, improves on these challenges. So what is modest monovision? Modest monovision means that from studies it has been seen that an anisometropia of around 1.3 to 1.5 diopters gives is well tolerated, and it gives the best balance of summation and near acuity. If the anisometropia is going to go more than 1.3 to 1.5 diopters, that is, if the monovision is vastly different, say 2 diopters difference in both the eyes, the patient is first going to have subtraction of the images, that is, the patient is not going to see, and later on the patient is going to develop suppression at the neural level. Similarly, stereo acuity and anisometropia are closely related, and it has been noted that stereopsis is inhibited minimally up to anisometropia of less than 1.5 diopters. As the anisometropia increases above 1.5 diopters, the monovision is going to hamper the stereo acuity. So, like I mentioned before, how spherical aberration is helping us in the depth of field. Essentially, it is just the circle of least confusion and creating a slight blur and telling our brain to adjust for that. So we can easily appreciate in this image without spherical aberration, as we go down the range of vision, it becomes significantly worse. But if the patient has some amount of spherical aberration, even though the patient is uncorrected, they are able to see fairly well. That is the positive effect of spherical aberration. Now, how do we use it? So in
So
an
can you
Yes,
Are
sir.
you now going towards Press Beyond?
Yes. I'm making the
No,
case
no,
for Press Beyond.
this is the build up for Press Beyond, right? So
Yes,
I was thinking, actually I have to leave for something, there's another engagement which I have to go for. Can we
sure.
continue this in a separate class? How much time for Press Beyond?
Uh,
You need
almost,
another
sir.
15 minutes.
Yes, sir. Yes, sir. Only 15 minutes.
So आप एक काम करो, आप
Hmm.
you continue with the class. I will log out, finish it. I will do this class with you separately for 10-15 minutes. You know, either in the clinic itself or this thing. So I don't want to disrupt the class. I think you should
Sure.
continue because it's otherwise the chain will break. Okay. But I
Yes,
will
sir.
have to log out and I will sit with you tomorrow or day after separately and understand what you're telling me.
Yes, sir.
Okay.
Yes, sir.
And also please make a recording of this class and I hope previous classes का भी हम लोग वो upload कर रहे हैं उनको.
हो रहा है सर, हो
So
रहा है सर.
make
Yes.
sure कि वो upload कर लें. And once you have uploaded, you can share the link on the Drishti.docs group also that this class has been uploaded.
Yes,
Whoever
sir.
presents. तो पुरानी classes का भी वहाँ link डाल देते हैं और आज वाली का भी डाल देंगे. Now I wanted to give you some homework for both of you that our next class can be on Monday evening, where if possible we can do a debate. Pranav speaks on the case for PresbyLASIK, and Shruti speaks on case for refractive lens exchange. Okay, with multifocal
Okay.
implant for treatment of presbyopia. Okay, so
Okay.
it'll be 10 minutes each. 10 minutes to Pranav and 10 minutes to Shruti. One person makes the case for PresbyLASIK as the preferred modality for treating presbyopia. The other person makes the case for uh, refractive lens exchange with either trifocal or EDOF lenses for correction of presbyopia. Is that a good idea?
Yes, sir. Yes,
Okay,
sir.
sir.
ठीक है. सो ये मंडे इवनिंग को करेंगे. अभी आप लोग दोनों ये प्रिपेयर कर लेना और ये वाली क्लास आप प्लीज कैरी ऑन करके फिनिश कर लो. आई
Yes,
विल
sir.
टेक दिस ओवर फ्रॉम प्रणव टुमारो. ठीक है. आई
Yes,
हैव
sir.
टू लीव
Dr.
नाउ
Ruchika
बट
ma'am
इट्स
is
वेरी
there, so
इंटरेस्टिंग
we
सो
will
प्लीज
get
कंटिन्यू.
expert comments
या
from her.
प्लीज कंटिन्यू विद इट एंड इट विल बी नाइस. यस.
Yes, sir.
ओके.
Yes, sir.
ठीक है. ओके. थैंक यू. थैंक यू.
Ruchika ma'am, should I continue?
Yeah, you continue, but I don't think I'm in a position to give. I joined, there was some problem with my Wi-Fi connection, so I joined just like, I don't know, 10 minutes back. Anyways,
प्रेस
you
बियॉन्ड
go
के
on.
बारे में मैं मैम फटाफट बता देता हूँ. प्रेस बियॉन्ड में एक्चुअली ज्यादा नहीं है बताने के बारे में. सो द मेन
हाँ,
थिंग अबाउट प्रेस बियॉन्ड is that beyond 1.5 diopters, if we are going to create an anisotropia to adjust for intermediate and near vision, we are going to have severe loss of contrast. So what we are going to do is, in the dominant eye, we are going to correct them for plano, in which the patient is going to get good intermediate and distance vision. For non-dominant eye, we are going to leave them minus 1.5 diopters, which is going to give them fair intermediate vision and good near vision. And this zone which is there for intermediate is going to be known as the blend zone. So essentially, right eye is distance dominant and the left eye is going to be near dominant. So press beyond is a modified binocular vision. So it is not monovision. Monovision means uniocular. Press beyond is a binocular vision and it improves on all of the problems that I mentioned before. So in traditional monovision, we see that one eye is good for good for near, intermediate is very bad. The other eye is good for distance and the near and intermediate are bad. So only 60 to 70% of the patients can tolerate traditional monovision. Press beyond, which is laser blended vision, is being tolerated by around 97% of the patients as per the study conducted by Reinstein et al. So what is press beyond? Press beyond is nothing but a non-linear aspheric micromonovision wherein we are giving a correction of pure presbyopia wherein the distance vision of the patient is normal. This is a profile of linear asphericity and this is a profile of non-linear asphericity. I don't know how to describe it, but pictorially this is how it looks. So we can correct plus 5 to minus 9 diopters of refractive error with a 3 diopter cylindrical correction. And the claims are that it is minimal compromise on contrast and night vision and functional stereo acuity is maintained and it is very well tolerated by more than 95% of the patients. So distance eye, in the dominant eye, we can see the tree very clearly at distance, the face at near, not very much clear. In the non-dominant eye, the face is clear, but the tree is not clear. So when the brain summates the two, we are able to see the tree clearly and the face clearly. So it is something known as 9-in-1 principle. The first principle is of monovision. We are giving a depth of field to reduce the anisometropia. We are doing spherical aberration control. We are centering the treatment on the corneal vertex. We are getting some amount of multifocality due to the epithelial lenticule after the healing. Once the image is formed, the retina is going to process it, the brain is going to summate it, it is going to get adapted to the blur and going to suppress the blurred image. So laser blended vision especially is using the brain to do half the work, neural summation and binocular fusion. So this is how it is eventually going to look. So now about treatment planning in PresBeyond. In PresBeyond, the target refraction is plano for distance size. I mean the dominant eye, the target refraction is plano. And between 1-1.25 to -1.75 diopters for near eye based on the age and micromonovision acceptance. So one huge advantage of PresBeyond is that you are going to use your existing examiner machine. You are not going to need any other special software, any other special scan, or any other treatment modality or anything other than what you already use for LASIK. This is using your existing LASIK apparatus to treat presbyopia. So in this, the platform is MEL 80 and MEL 90 by Zeiss. You are going to do all the scans, import it onto the machine and do the treatment. So what is special about the newer advances in PresBeyond is that you are able to consider the pre-op spherical aberrations also. There is greater flexibility of optical zone while planning the treatment, and also we can include the patient's functional age while treatment. What are the advantages of PresBeyond over Supracore and PresbyMax? It is most importantly not dependent on pupil size. It has a wide variety of refractive errors which can be corrected. The patient has very clear, intermediate and near vision and does not have night vision problems and contrast change, which is being done because of the multifocality on the cornea. So multifocal IOLs and multifocal cornea are going to have similar problems. So that problem of multifocality on the cornea or the IOL is not going to be there for the PresBeyond. So how is the PresBeyond going to work? We are increasing the tolerance to the blur. So the -1.5 defocus, the patient is going to see very blurred. If you reduce the pupil size, the blur is going to reduce little bit. If you add spherical aberration onto that, the blur is going to reduce even more. If you are going to look at it binocularly, the brain is going to summate it and then eventually create a clear vision. So you're using three things. You're using the small pupil size for near, which is a part of the near triad. You're using the induction of spherical aberration, which is happening with wavefront optimized. And also you're using the neural processing to create a clearer image for near. So this is the kind of interface we have in the right eye. This is the manifest refraction. The target refraction by default in the dominant eye, which is the right eye, is going to be plano. In the other eye, the manifest refraction is the same, but the target refraction is somewhere around -0.75 diopters. In the newest machines, what you can see is we can include the functional age and if the patient has tolerated the 1.5 diopter test or not and the dominance of the eye. Similar to the ablation profile which I mentioned in Supracore and PresbyMax, in the dominant eye, this is a straightforward myopic ablation profile, and in this we are having this donut shaped profile in which in the center we are not ablating that much to create a central hyperpositive hyperprolate area, but in this donut shaped green area which we see is the mid periphery wherein we are treating to create the intermediate, and then more flattening in the periphery to create the distance zone. So central is the near, wherein we are not correcting that much. Mid periphery, where we are doing moderate amount of flattening, and distance area where we are doing a lot of flattening. So what are the take home points of this class? Pre-op evaluation is extremely important, and you need to understand patient expectations. You have to under promise and over deliver. In PresbyMax, we have three kinds of treatments: micromonovision for patients who are tolerating distance blur very well; hybrid, in which the patients are moderate tolerance for distance blur; and monocular treatment, in which the patient does not accept distance blur at all. In supracore, we have two options: soft supracore and regular supracore. In soft supracore, in the dominant eye, you are going to have plus 1.5 diopters add. In the regular, you are going to have plus 2 diopters add. So Press Beyond is pupil independent. It has higher patient satisfaction, and we need to tell the patient post-operatively that you need time for adaptation, and it is not like a straightforward LASIK treatment wherein you are going to see 6 the next day, and reversal of treatment is possible in PresbyMax and Supracore. So these are the overall things that we can take away from the class. So that is the end of my class, ma'am.
Yeah, I mean, nicely covered, although I missed, I think, a chunk of it. But
Yes,
yeah,
ma'am.
even your summary was good enough to understand. What time did the class start?
Ma'am, 8:10, 8:15.
Okay. So I think sir will catch up the end of the class with you, and I will catch up the beginning
Yes, ma'am.
part of it.
Tomorrow I'll come to your chamber and discuss PresbyMax and Supracore, ma'am.
Yeah, right. So yeah, I think Supracore tak मैं थी, like when you were speaking on Supracore, I was there. So yeah, maybe
Yes.
I'll have to. But yeah, interesting. So good, something new. I mean, we've not over these years we never had a discussion on correcting presbyopia.
मैम
So
प्रेस बियॉन्ड वी कैन डू नॉर्मली हमारे इसमें प्रेस बियॉन्ड तो हम कर सकते हैं इनफैक्ट प्रेस बियॉन्ड में भी एग्जामर में क्यू वैल्यू बेस्ड अप्रोच भी होता है फॉर प्रेस बायोपिया करेक्शन जो मैंने इतना डिटेल में पढ़ा नहीं है बिकॉज इट इज नॉट routinely done but हमारे मशीन में we have the option so we can possibly do that by altering the
yeah,
k value
true.
post operatively.
Yeah, we can. So let's see if we have any potential patient, because we have done a few patients, in like in their 40s also. तो उनमें हमने like वही थोड़ा सा मोनोविजन टाइप का ही किया है. We've not used too much of a like this kind of a concept in it, but yeah, we've done like a simple sort of
Monovision type हाँ
leaving them a little, yeah, monovision. Yeah, that's what we do with them.
तो मैम next time we can try playing along with inducing monovision we can try playing around little bit with the
And,
q value.
there are patients who are more like pre-presbyopic. They're like 39, 40. They've still, they're not using near ad yet, but with a slight monovision, you can just sort of postpone, or tell them that maybe, yeah, just postpone the use of near ad by like maybe a few years or few months. That's it. But we've not done it. I mean, yeah, we have, but very few patients who are like full blown presbyopic, and then we've clearly told them that we are only correcting you for distance.
मैम एक
Yeah.
डाउट था मुझे कि all of these treatments no they are talking about leave aside Presbymax and Supracore which need their own algorithms and nomograms and their own planning software to do everything to create the multifocality and everything. So this Press Beyond which is there, why does it have to be only done by the flap based procedure? मतलब स्माइल करके भी ये तो कर ही सकते हैं ना, क्योंकि उसमें
नहीं, how would you?
प्लेन फंडा इसकी दूसरी
हाँ.
आंख में -1.5 डाप्टर्स रखना है, तो दैट एनी वे यू आर एबल टू डू विथ स्माइल. तो इसमें पूरा ये जाइस का नया टेक्नोलॉजी है और प्रेस बियॉन्ड है एंड CRS मास्टर है एंड मेल 80 मेल 90. व्हाई डू यू नीड दैट? You can very well do it on your Alcor machine or Nidec or Schwind or whatever. उसमें तो टेक्निक सेम ही है. फाइल से भी हो सकता है, सरफेस से भी हो सकता है.
No, but how do you create this, like whatever you're talking about, that super prolate zone, वो कैसे create होगा तुम्हारा?
नहीं, वो प्रेस बायोपिया.
Hyperprolate or
हाँ,
whatever.
वो प्रेस बियॉन्ड में हाइपर प्रोलेटनेस जो है. हाँ, यस.
हम्म,
बट
वो
मैम,
तुम्हारा कैसे create होगा? Especially with smile तो चांस ही नहीं है.
करेक्ट. ओके, सो मैं आई विल रीड मोर अबाउट दिस. आई हैव कंफ्यूज्ड माय ओन सेल्फ विथ माय क्वेश्चन.
So yeah,
हाँ, अच्छा मैंने ही
that's why
बताया ना कि वो
that's
अब्लेशन
also
प्रोफाइल में डोनट पैटर्न आना चाहिए, तभी तो इट विल बी दैट. सो इट इज नॉट
exactly, and that is
प्योरली.
the reason why, that is also the reason why we are not using smile to do hyperopic correction ना. तुम स्माइल में कैसे करोगे वो चीज?
करेक्ट करेक्ट करेक्ट. गॉट इट.
And you will not get that the multifocality and the central hyperprolate thing you cannot even get with a regular like
लेसिक.
the
करेक्ट.
approach that we use for LASIK. Yeah,
यस मैम.
that's why sir was talking about that other thing कि जिसमें तुम जब hyperopic presbyo को correct करते हो तो by default the slight the prolate zone that is created in the center उनको थोड़ा advantage मिल जाता है. But it's
यस मैम.
obviously not equivalent to what you are talking about.
यस मैम.